Thanks for downloading and welcome to Take Orally, the podcast from Dreamkids Medical Centre, Nottingham. In this episode, we'll be discussing the child with a fever. As ever, all information is correct at the time of recording. Any and all guidelines mentioned are correct for Nottingham University Hospitals, NHS Trust. Other trust guidelines may vary. All views and opinions are the speaker's own. Hello, welcome back to Take Orally, and in this episode we're discussing the child with a fever. I'm delighted that Dr. Rachel Trix is once again joining me. Hello again, Rachel.
Hello, how are you?
I'm very well, how are you?
I'm not too bad, thanks.
Marvellous. So this episode is going to overlap quite a bit with some other podcasts we've done. You and I have already gone through paediatric sepsis, and myself and Colin also went through the collapsed neonate. So we're kind of bringing some of those things together as well within this episode.
Yep.
We're going to be having a look at the initial assessment of a child coming in with a fever and the traffic light system that we use.
Yes.
Is that right? Cool. So child comes in with a fever, has felt hot at home. Mum and dad may have a thermometer themselves, or has been identified as having a fever in A&E. What's our initial assessment going to be then?
Well, like any unwell child, initial assessment, you should take a nice ABCD approach, and making sure we've got some observations. So standard observations: heart rate, temperature, respiratory rate, SATs, capillary refill time. So nothing unusual.
Sure, cool. And in terms of the heart rate as well, we're looking for tachycardia, obviously, which depends on their age.
Yes.
Which I think is the thing about paediatrics, to get your head around and remember that.
Yes. Any child who has a significant tachycardia is at least sort of in a significant intermediate risk group. So we define that as sort of under 1, a heart rate of over 160, 12 to 24 months, 150 and over 24 months, 140, but even as you start to get into your older children and adolescents, that's still quite high. So
Absolutely.
So yeah, it changes, and if you've got any concerns, look it up on the guidelines. They're all on pews and charts, so assess it with that.
So in front of us we've got our own QMC Nottingham Children's Hospital guidelines. These are very much based on NICE guidelines as well. So at this point, do you want to talk about the traffic light system used in the assessment of a child with a fever?
When NICE first wrote their febrile child under fever in the under 5s guideline, they came up with a really nice traffic light system, which has green, amber and red features in it to assess how sick your child is. Often it's quite difficult with a child who's hot, because not only are they hot, but then they also have a tachycardia associated with that. Their respiratory rate's often quite high with that, and trying to differentiate between the child who's hot and miserable because they're hot, or the child who's hot and unwell can sometimes be quite difficult. So NICE have tried to help us with their traffic light system. Green obviously being low risk, so the main green factors are things like children with normal colour, they're responding normally, they're happy, they're playing, smiling. If they're asleep, then they'll wake up nice and quickly, or they're generally awake anyway. They've got a normal cry, or they're not crying, as opposed to an abnormal cry. They have nice moist mucous membranes, they've got normal skin, and it helpfully puts the final green factor is that they've got none of the amber or red symptoms or signs. As a nice get out clause.
Nice to clarify that. I think it goes quite well with that Delphi study you mentioned in the last podcast as well, about how reassuring the happy child is, who may have temperature but is happily building Lego and just cares about that.
Quite happily sat there playing on their iPads, however they want to, whatever they want to do, but generally good. Good.
Okay, so then what about our amber? What about our intermediate risk factors?
So our amber intermediate risk factors are those that sort of put us somewhere between the well child and the child that we're worried about sepsis, so the ones that we previously talked about with the red flags. So they might be a little bit pale, they might not be responding quite as normally, they might not be as happy and as smiley, they might be a little bit miserable, crying, not smiling, might need a bit more waking up, want to sleep a bit more than normal. in terms of assessing their respiratory and cardiovascular signs, they may have a slightly raised respiratory rate, and that will depend on their age, which again you can find on a Pew's chart, age dependent. They might have slightly lower saturation, so they use the cutoff here as less than or equal to 95%. They might have crackles in their chest, so all things which are pointing to possible respiratory infection. Again, they will possibly have a tachycardia, a possible prolonged capillary refill time, dry mucous membrane, signs that maybe they're not eating or drinking as well as they should be, and reduced urine output and poor feeding in infants is included in this as well.
Cool. So an absence of wet nappies, those sorts of things,
so we generally say at least one wet nappy every 10 hours is a bare minimum, but ideally more than that.
Sure.
They also put in this category some certain features around the temperature. So if they've been having a temperature for more than 5 days, then there might be something else underlying this. If they've got rigors, any signs of any localized infections. So always remember to look for swellings of limbs and joints in children, or if they're not weight bearing. So just because they don't have an ear, nose, and throat or chest infection doesn't mean there's an infection going on somewhere. So always make sure you're looking out for other places. And also into this category falls our 3 to 6 month olds who have a temperature of over 39, and we almost treat those like our under 3s who have a temperature of over 38. So they kind of fall in the same category.
Okay. And so then we're into our red area.
So this is really going back over sort of the signs that we talked about previously with sepsis. So your pale, mottled child, they're not responding to you, they're not waking normally, they've got a very high respiratory rate, they're grunting, they're working hard with their breathing, they're looking dehydrated, prolonged capillary refill time. And these ones this again includes our under 3 months with temperature of more than 38. And then the specific signs again, so we've talked about non-blanching rashes, and any signs of meningitis, so bulging fontanelles, neck stiffness. If they're having seizures with a temperature, then that's obviously a significant finding. If they're in status, we know that febrile seizures happen, but most often that your child with a febrile seizure will be recovering by the time they come into the ED. A child who's got a significant infection related to which is causing their seizures, and their high temperature generally will still look very sick when they arrive in ED.
So a febrile convulsion still included as a red feature. If you think it's a FebCon, do you think is that a red flag feature?
No, so for a febrile convulsion where the child's returned to normal, that I wouldn't consider that to be a red feature. Cool. Febrile convulsions are quite common in a lot of viral illnesses, as we might go on to talk about in other podcasts.
Absolutely.
These children are often back to normal by the time they come to see you, or at least coming back to normal. It's those where they're really not returning to normal, they're still fitting.
Or they're in status, Cool. Okay, brilliant. So those are our sort of red flag, that's our traffic light system, which I think, as again is based on our guidelines, but it can be found very much through the NICE guidelines as well. So we're now going to break down our patient into the under 3 months and the over 3 month year old. Now my understanding of this is based on that in your first 3 months of life you've got your maternal immunoglobulins going around, which should fight off most viral infections. And so if a child comes in that age and around, we're more concerned it's a bacterial.
Exactly.
Is that right?
Yeah. So unless you've got a child who you can quite clearly see has a obvious viral illness, your broncholytics, and similar to that, then really if they've got a temperature, you should be starting them on antibiotics and working them up for a serious bacterial infection. Even with bronchiolitis, we don't expect to have more than a very low grade fever, sort of 38.1, 38.2 as maximum. So any child who's got high, or I should also add a very low temperature, should be considered as having a serious infection. Cool. So they need a full septic screen, including chest x-ray, lumbar puncture, and urine analysis at the earliest opportunity, and antibiotics ideally within the hour, as our sepsis guidelines say.
So I think there's a lot of this is we already discussed in the paediatric sepsis podcast and the collapsed neonate podcast as well, about the investigations that we need to do, and the possibility of a lumbar puncture as well. And we already talked about an early lumbar puncture, before antibiotics,
ideally, if possible. Definitely.
Absolutely. And so then, how about the child over 3 months old? What are the differences there?
So then they quite helpfully sort of break it down on how many red or amber features the child has. So a child who has one or more red features, if you can't find a appropriate source, and they have one or more red features, then you definitely need to be treating this as a possible sepsis or where significant bacterial infections. So they all need investigations performed. So they need bloods doing with full blood count, blood culture, CRP, and the urine done at the same time. Depending on what else you find, so if this child has signs of meningism, then it's they need a lumbar puncture, if it's safe to do so. They potentially need a chest x-ray, and if you're worried about them, then it's always worth doing electrolytes and blood gases as well, because they provide a lot of information. So if you've got one or more amber features and you can't find a source, then it's worth getting a senior registrar to have a look at the child.
ST4 and above.
So ST4 and above. Have a look at the child, and they may be able to guide you, but generally we need to consider things like urine and blood tests, potentially chest x-rays and LPs as well, depending on what their findings are. Okay.
Sure. And if they only have green features?
And if they only have green features, then unless you can find a source of fever, it's worth always checking for a urine sample, and making sure there's no signs of a UTI there. But chest x-rays are generally not performed, and we shouldn't be doing blood tests either. So hopefully, as long as they're all in the green, they should be able to go home.
Cool. And then we've mentioned a little bit about finding a source. So I suppose, like the chest source, you kind of, it's kind of self-explanatory really. Should we just touch a little bit on about what makes us think about a particular source in these patients?
Yeah, so the important thing to do, I think, in all children who present with a fever is a proper Ent examination.
Okay.
Upper respiratory tract infections are still one of our most common, and probably increasingly so, attendances at the A&E, and a good Ent exam is hard to do. It needs cooperation from the child and the parent, and if you're not happy with how this is done, it's sometimes worth letting the child settle down, coming back a little bit later, but making sure you've done that before you discharge them anywhere. If your Ent examination is normal, then other places to start thinking. So obviously our most worrying things are meningococcal sepsis and meningitis. So for your meningococcal disease, you're looking for your non-blanching rash, your ill-looking child, and other signs of sepsis and shock. And meningitis specifically for the meningeal irritation, so neck stiffness, reduced level of consciousness, possibly convulsive status.
Yeah.
And in the little ones, a bulging fontanelle you can often find. Herpes simplex encephalitis is also something to consider, particularly in your young ones again. They often are more likely to present with focal neurological signs, focal seizures, often quite drowsy or with reduced level of consciousness, and it's always worth asking family members, is there any history of cold sores and contacts, because that's often the way, particularly in newborn babies. You'll find someone will have inadvertently kissed the newborn baby but had a cold sore, which is not a good idea. Don't recommend it.
I'll bear that in mind, a bit of advice there.
And then sort of away from that, we've got our sort of pneumonia, urinary tract infections. They'll possibly have specific signs. So your pneumonia, you'll have signs of increased work of breathing, crackles, reduced saturations. Urinary tract infections can be quite hard to diagnose, particularly in the little ones, because they don't have the obvious signs of cystitis. But any child who's vomiting, poor feeding, should have a urine done, and a UTI should certainly be considered.
Sure.
And the other thing I mentioned earlier is don't forget joints. Joints and limbs. So a child who's not weight bearing properly or might have pain on moving a limb if they're little and then non-weight bearing anyway, then it's always worth having a look for septic joints as well.
And there is a podcast on the child with a limp as well.
There you are.
Sufi or not Sufi, that is the question.
Well, yeah. I hope there's no Sufis in the under fives.
No, that's good. Yes, very good point. And we're also down there is Kawasaki disease.
So down there at the bottom is Kawasaki disease, and this is something that potentially we're going to talk about in a future podcast a bit more detail. But it's certainly something to be aware of in children who've had fever for more than 5 days, and that's why this is one of our amber features.
Yeah.
It's a immune vasculitis, and they often present not only with fever, but they also have to have 4 of the following. So they either bilateral conjunctival injection, changes in their mucous membranes, a polymorphous rash, possible desquamation of the hands and feet, and they also have cervical lymphadenopathy. So it's something always to be aware of when you're looking at a child with fever, and when mum comes in and says they've been unwell for days, so don't forget it.
Cool. And then, so shall we now talk a bit about the management of our child with a fever? So obviously you've got to decide does the child need antibiotics, depending on what you're diagnosing them with, and there's antibiotic guidelines out there. We're not going to go through that, but follow your trust guidelines.
Local policy. So in terms of sort of managing the fever, it's actually advised that we're not tepid sponging them and we're not undressing completely children. So take them down to a normal level of clothing and let them sort of relax.
We don't have to mop their brow.
We don't have to mop their brow. I'm just thinking, so the next line actually, if you look at our guidelines, says antipyretic agents do not prevent febrile convulsions and should not be used specifically for this purpose. Okay. Which is true. And I think there's lots of anxiety out there about giving paracetamol to keep children's fevers down so they don't have a convulsion. And I think there's probably a whole nother podcast for you out there in the febrile seizure.
There is. You're talking yourself into more podcasts here,
exactly.
I mean, that's a whole debate anyway in itself about the fever is your natural body's response and should you actually be suppressing it?
Exactly. And there is a difficulty. I think the general consensus, there's been quite a lot of Twitter debates about this in recent months, so you can look out there
Absolutely,
for it. But I think there's a difference. Giving paracetamol and ibuprofen to treat a fever alone isn't the way that we should be going forward. However, giving paracetamol and ibuprofen to treat an unsettled, agitated child who isn't comfortable is a different matter, because when we're ill with colds and flus, we all head straight for the paracetamol and ibuprofen, so
Lemsip all the way.
Exactly, so we should be certainly considering it from that point of view. And one of the other things is that often advise parents not to use them simultaneously, because they can have 4 doses of paracetamol a day, 3 doses of ibuprofen, and actually by giving it, sort of spacing it out every couple of hours, you get far better cover out the day.
Yeah, rather than taking it in.
Cool. And there doesn't have to be a time limit between the paracetamol and ibuprofen, just between the same drug. That's one of the other questions that often get asked when parents come in, so make that nice and clear.
Anything else about the management you'd like to talk about?
Not in particular, but then obviously we've got to decide why this child is coming in or going home. If we're going to admit this child, then they need to be admitted and observed. And generally, children, certainly with amber and red features, even if we're not treating them initially because we've decided for whatever reason we don't think they have bacterial infection, they often need to be observed at least for a couple of hours in the department and see how they go. Children are very good at sort of declaring themselves either to be better or worse in most cases, not every case, but I think we often talk about the 4-hour wait in A&E, and actually 4 hours is a really good time to observe a child, and we don't have to make snap decisions on these children whether they need to come in unless we're concerned. And actually, if you can get a child comfortable, settled, making sure they're drinking, making sure they're passing urine, watch their observations, see how they play, then you can be encouraged that these children might be able to go home if you're happy with them. Certainly the children with green features can generally go home. It's important that we're providing parents with written and verbal advice on when to come back and where they should come back to.
Sure.
Other advice, so we just talked about how parents can manage fever, making sure they're encouraging drinking and eating. I generally say it's the time where to allow them to eat anything. I don't often say that. But no, that is the time, and just to keep a closer eye on them than they would normally do.
Yeah.
And avoid play school or school until they're feeling better.
Cool. That's the bit you like as a kid.
Yeah, exactly.
Off school. Or at least I did. Anyway, cool. And again, as you said, the advice, written advice as well. Most places you'll have a leaflet.
Yeah.
If not, Google, NHS will give you there's a guideline for something.
There's
you can
always
print off.
something
We talked about that in the last podcast about OSCE advice. There's always a leaflet.
There's always a leaflet.
Brilliant. And if in any doubt, speak to a senior.
Yes, and I would reiterate that there should always be someone around, and if you've got concerns, then don't hesitate to ask.
Marvellous. Thank you so much, Rachel.
That's right.
Thank you. Bye-bye. That was the Take Orally Fever in Children podcast. You can find the blog entry and take visually for this podcast at www.takeorally.com. Remember, Take Orally can be found on both Apple Podcasts, Spotify and SoundCloud. We're also on Instagram as well. For more information about research and education opportunities with emergency medicine, acute medicine, major trauma, you can find NUH Dream on both Facebook and Twitter.